Okay, Ahmed, I already see your comment. Thank you. That's the first person. And I see that three people, okay, two people now stayed with us. So please join us. In 5 minutes, I would like to start this lecture. Tell others that the link, direct link to our lecture, they may find on our website. So please tell them to join us to watch this lecture. Oh, you know what to do. Yes, exactly. People who is joining us, please write your name and the number of your group to the live chat of our lecture. Okay, hello people. Nice to see you in the live chat of our lecture. Today we are on the next stop of our route of pathology. My name is Alexander Bondarenko, and I introduce you the next lecture, which is dedicated to a very important organ in our body, that's the liver. We'll discuss today eventually about diseases of liver. This lecture is embracing different points of liver pathology. First of all, I would like to stop on the normal anatomy of a liver. Also, we will discuss about patterns of hepatic injury and repair of the liver. Uh, we will discuss particularly about the liver failure and cirrhosis. Then my story will be continued on viral hepatitis with the case presentation number one. Uh, then we'll continue with the alcoholic liver disease, which is also very important in nowadays and in the future, I guess, and also will be quite important. Then inherited metabolic liver diseases, autoimmune diseases of liver, and we will finish with the liver cancer with another case presentation. First of all, I want to ask about the feedback from you. So please tell me if do you see everything correctly, if you hear me properly or not. So please write all your complaints into the chat. But first of all, just write your names, write your group and subgroup, and with that I will put this information into our lecture registry. So hello everyone again, and if everything is okay, I just need your confirmation in the chat. If everything is okay, we can continue this lecture. Okay, everything is okay. Thank you, Naif. If everything is going okay, let's go. Well, uh, as you may know, that liver, that's exactly the organ which is placed on the crossroads between the digestive tract and the rest of the body. The liver has the enormous task of maintaining the body's metabolic homeostasis. That's like the storage of our body. That's the energetic plant, the uh, plant of different substances that which are required for different functions. So, like processing of dietary amino acids, carbohydrates, lipids, vitamins, synthesis of serum proteins, together with detoxification and excretion into the bile, different types of endogenous waste and xenobiotics, which couldn't be excreted by kidney, for example. So that's why there is no surprise that the liver is quite uh, vulnerable to the different types of metabolic, toxic, microbial, and circulatory factors that can cause the disease of this organ. So, anyway, the liver has enormous functional reserve, and regeneration occurs in all, uh, even in the most fulminant of hepatic diseases. Even after the severe injury, this organ could be restored. And you can imagine how much efforts the person must apply to damage this organ irreversibly. First of all, now I'm talking about the alcoholic injury of this organ. So you may know the tale about mm, some ancient Greek hero, that's the Prometheus. You remember that the eagle just ate the part of his liver, and every day this part of liver was restored. And indeed, the surgical removal of 60% of the liver in a normal person could be followed by minimal and transient hepatic impairment, with the restoration of most of its mass by regeneration within 4 to 6 weeks. However, this progression of diffuse chronic disease or disruption of the circulation of bile flow, the consequences of deranged liver function become severe and even life-threatening. So, as you may see, this function of the liver, normal function of liver, is supported by the functional unit and anatomical unit of the liver. We call this um, acinus or lobule, depending on the conception. So the point of view of the acinus model, that there is the basis of blood flow, that's based on the blood flow from the periphery to the center. You see that the acinus or even lobule is supplied by two type of vessels. That's their different branches of vena porta, because as you remember, liver is supplied by the portal vein, and by this way all the nutrients which are absorbed in the digestive tract are delivering into the liver exactly by the portal vein branches, portal system. uh, Oxygen is delivering anyway, but by artery. So you see the double entrance into the liver tissue by two types of vessels, both vein and artery. So the small vessels of these types finally are located in the peripheral zone, and they are divided into the small branches and the sinuses of the liver. Finally, the blood is flowing through this zone from first to third, and all the blood is collecting in the central vein, which in its turn is the branch of the vena hepatica, and finally there's the branch of vena porta. So you see, between these sinuses there are the functional cells. That's the hepatocytes, and these hepatocytes, that's exactly the functional cells of the liver. You may see certain histological structures of the histology. There's the so-called hepatic triads. The components of hepatic triad, there's the three structures, three tubular structure. There's hepatic artery, bile duct, and the portal tracts. You see, that's the morphological. How do we see the liver tissue histologically? Exactly, the bile duct. Okay, sorry, I just see the bile duct, the vena porta, and somewhere over there the artery. And then there's the hepatocytes between them and the central vein over here. So just to remind you the normal structure of the liver. However, in case of the injury, we have deal with the very familiar, already familiar for you type of injury, what we call necrosis. Necrosis, that's, as you remember, the irreversible injury of any type of cells, and liver is, that's another exclusion. Necrosis is the predominant in case of ischemic or hypoxic injury and oxidative stress. So what do you see here? You see that the hepatocytes, at least some of them, already lost their nuclei, and due to the injury of the cells, we see the cytoplasm is becoming pale, is becoming hydropic. That's the swelling of the cells due to the ischemic injury. In some cases, however, we can find another type of the hepatocytic injury. That's the apoptosis. Apoptosis, as you remember, is the programmed cell death, and morphological appearance of apoptosis very frequently we may find as the concealment bodies, which is equal to acidophil bodies. You see, they are indicated by single arrows. What does it mean, acidophil bodies? Acidophil bodies means that the structures are stained intensively by eosine, and you see that's reddish structures. That's exactly the hepatocytes which underwent apoptosis. How to prove that this is the apoptosis? Yeah, you see the fragmentation of the nuclei. When, in which cases we may see the development of such kind of events, especially I'm talking about the massive necrosis of the liver. So, massive necrosis of the liver, that's the feature, morphological feature in many diseases. For example, in case of fulminant hepatitis, in case of the severe poisoning of different substances like mercury poisoning, poisoning of some mushrooms. But one of the example, as here, then you see, is associated with acetaminophen toxicity. So you see, microscopically, there is the development of massive necrosis, which appears as the pale pink areas. That's exactly the necrotic hepatocytes. So this widespread parenchymal loss could be consisted of different types of necrosis. That's like subtypes of exactly the liver-specific necrosis. One is the confluent necrosis, when you see the severe zonal loss of hepatocytes that may begin as the necrosis around the central vein. For example, acute toxic or ischemic injuries, fulminant hepatitis. In other cases, we see the necrotized zone that may link central and central portal tracts or central veins to portal tracts. It's like the bridge between them, or they can appear, these areas of necrosis, as a bridge between adjacent portal tracts. This type of necrosis we call bridging necrosis. You see, I just put that into the red frame just to memorize this statement, that the process of extensive hepatocyte loss and collapse of the supporting framework occurs in many types of liver disease. That's like universal feature, universal type of the liver tissue injury. The resultant cirrhosis, that's the common form of liver disease too. That's like the outcome of the necrosis. On this slide, I just want to describe you the different types, different patterns of liver injury according to the changes between different compartments of the liver structures. For example, see in the normal appearance, you see the more or less even distribution of the triads. See, they are in triangles. They are more or less on the same distance from the hepatic vein. However, in case of extinction, massive extinction of the hepatocytes, we see that they die and they form some areas of the pale areas of the necrosis. Later, these areas of the necrosis could be replaced by the connective tissue, but anyway, the connective tissue appearance doesn't replace the same area because we have to deal with the collapse of the hepatic tissue. That's why the empty parenchyma collapses and begins to scar. That's the brown color. And adjacent portal tracts and hepatic veins become approximated. See? That's the veno-portal approximation. That's another pattern of the pathomorphological changes in the liver. However, sometimes we may find that the scarring is not even in certain areas. Sometimes in some regions, extinction, contract, and condense, becoming fibrous septa. The larger region of extinction of the left has formed a short adhesion between adjacent portal tract and hepatic vein. And also we see that small veins also disappeared. Sometimes we may find that there is the elongation of the septum. So this creation of the septum is becoming longer. Why? Because there is the traction caused by hyperplasia of adjacent hepatocytes. So they are proliferating and create some kind of traction of this scar tissue. And even later, we may find that this scar tissue may disappear due to the remodeling of the fibrous tissue. There is the resorption of septum and resorption of adhesion. Just in case if the patient completely abandoned, for example, to drink and there was some resource for restoration of the liver activity. Some cells, they have very important role in the development of the fibrous changes and the cirrhotic changes in the liver. For sure, I'm talking about so-called stellate or ethos cells. The interaction between other cell populations like endothelial cells, Kupffer cells, and for sure downstream effect on the liver could be realized in this schematic. So first of all, we have deal with the activation of Kupffer cell. That's the macrophage, residual macrophage, which could be activated by different factors. For example, by different cytokines which could be produced in the inflammatory disease like chronic hepatitis by different reasons. Activated Kupffer cell by itself can release other types of cytokines like cytokines responsible for proliferation, different growth factors, and this growth factor directly induce awakening the quiescent stellate cells. They are starting to proliferate and they are becoming similar to myofibroblasts. And these myofibroblasts, on one hand, can contract, and also they can produce the extracellular matrix proteins like collagen fibers. Also the downstream effect of the activated Kupffer cells could be released into the dysfunction of hepatocytes and their apoptosis. So it also may lead to the extinction, certain extinction of the functional cells. All of these events, the events of which are concerned with the extinction of the hepatocytes and their dysfunctioning, altogether lead to the general effect that clinically we call as the liver failure. Liver failure may follow acute injury or chronic injury, but may also occur as an acute insult superimposed on an otherwise well-compensated chronic liver disease. That's very good to memorize the liver failure features by the mnemonic. Mnemonic for causes of acute liver failure. See, ABC is like an ABC. For A, we mentioned acetaminophen, hepatitis A, and autoimmune hepatitis. That's something that may cause acute liver failure. For B, that's hepatitis B, also may lead to that. Hepatitis C, cryptogenic, not rather will induce acute but rather chronic liver failure. Anyway, that's about liver failure. D for drugs, toxins, and hepatitis D also is associated with the development of liver failure. E for hepatitis E or some esoteric causes. Esoteric, that's the very weird word in this case, but anyway, you should remember about some rare, means esoteric in this case, rare diseases like Wilson disease, as you remember, which is associated with the copper accumulation, and Budd-Chiari disease, which is associated with the local thrombosis in the liver vein. F for fatty change of the microvesicular type, like fatty liver of pregnancy, valproate, tetracycline, Rye syndrome. Serious and sometimes fatal sequelae of liver failure include parenchymal jaundice, coagulopathy, encephalopathy, portal hypertension, bleeding of esophageal varices, hepatorenal syndrome, and portopulmonary hypertension. That's the clinical features of the liver failure. Acute liver failure morphologically is associated with the massive hepatic necrosis that's indicated with the arrow over here, with broad regions of parenchymal loss surrounding islands of regenerating hepatocytes indicated with asterisk. Livers in this case are becoming small and shrunken, and you see the diffuse microvesicular steatosis, accumulation of the fat, and grossly it appears as the yellowish coloration of the liver cut surface. So you see the collapse leads to the shrinking of the liver parenchyma, becoming small and yellow. Chronic liver failure basically associated with the cirrhosis development. In case of the micronodular cirrhosis, we see that the regenerative nodules average 3 millimeter or less in size. The yellow-brown appearance of these nodules is caused by concomitant hepatic steatosis. You see the hepatic steatosis concomitant in many cases. It's like also the stereotypic hepatocytic injury. So, micronodular, small nodules, that's the formation of fibrosepta, and between them we see the regenerative nodules, hyperregeneration of the hepatocytes. Sometimes we may find the cirrhosis which appears as the macronodular, which means the large nodules due to the cirrhosis. For example, in case of the chronic viral hepatitis B, This is the view from the inferior hepatic surface, and it demonstrates the multiple nodules greater than 3 millimeter in size, with extensive deposition of tan appearing collagen surrounding these originative nodules. Microscopically, micronodular cirrhosis uh, as is demonstrating here at a low power. You see the regenerative nodule of hepatocytes. These nodules are surrounded by thick areas of collagenous tissue, as the fibrosis, and within the fibrous bands, you also may find the confirmation of ongoing chronic inflammation. That's the lymphocyte infiltrates and proliferation of bile ducts. So you see, cirrhosis, that's altogether the hyper regeneration of the hepatocytes and simultaneously fibrosis of liver. So altogether we call it cirrhosis. You should also realize that this hyper-regeneration of hepatocytes is not adequate to the situation in the liver, because there is no formation of the adequate blood circulation here. That's why there is no normal evacuation of the metabolites. There is no normal blood flow over here. That's why that's inadequate regeneration. Sequela of liver failure and such a way the clinical superficial appearance, clinical symptoms of the liver could be resumed in this schematic. You see that the sequela of liver failure associated with the coagulopathy. That's why you may find some hemorrhages in this patient. Encephalopathy, that's the result of the toxic injury of the brain, toxic injury due to the accumulation of the toxic products, lack of detoxification products, portal hypertension due to the lack of the blood flow through the liver, fibrotic liver, cirrhotic liver. We see the development of the plethora, congestion of blood in the portal system, together with the splenomegaly, and together with the involvement of the bypasses of the blood. That's the different portal-caval anastomosis. That's the anastomosis between portal system and vena cava inferior. So this type of anastomosis, we may indicate the esophageal varices, esophageal veins. Esophageal varices, that's the congested esophageal veins. Peri-umbilical veins, finally, they demonstrate, reveal the clinical symptom in caput medusa, and the development of the hemorrhoids. Together with the coagulopathy, you may realize how dangerous is bleeding of these damaged veins. Also, you see the development of the ascites. It's also the sign of the portal hypertension. Then the testicular atrophy, that's the lack of the hepatocytes which can metabolize the estrogen. Estrogen is not neutralized in the male organism, and in such a way you see development of the testicular atrophy. So, and for some reason we see development of the skin spider angiomata. Also, there's the lack of neutralizing of certain growth factors and hormones which may induce the development of this telangiectasis. Malnutrition also could be as a result of the liver failure. So I just show you this ancient Greek that's portrayed villain. That's the Medusa, so-called Medusa, the very evil woman, though quite beautiful. But anyway, the if ancient heroes looked at her, they became stoned. They are transformed directly, turned into the stone. And you see, instead of the mm, hairs, she got the snakes, and this look like very umbilical veins. And you see that's here. It's look like Medusa. You see that's a result of the portal hypertension. Hepatic encephalopathy, microscopically, could be released into the proliferation of the Alzheimer type 2 cells in the lower layers of the cortex and in the basal ganglia. Enlarged protoplasmic astrocytes with watery nucleus. See, no visible cytoplasm and prominent nucleoli. These changes, formation of these Alzheimer type 2 cells, that's the result of the toxins impact, for example, ammonia formation. And they are not cleared by the urea cycle in the failing liver. Next point of our lecture, that's the viral hepatitis. You see on this table, there are represented 5 types of different hepatitis. There's A, B, C, D, and E. And despite the affinity, the tropism to the liver, there's like hepatotropic viruses, they have different nature. They are very different. For example, hepatitis A virus, that's the double-stranded RNA virus. Hepatitis B, that's the partially double-stranded. C, it's also double-stranded RNA virus, but it is related to the Flavivirida family, and it belongs to the so-called Delta. Hepatitis E, herpesvirus family, it's also a double-stranded RNA virus. These viruses, they got different routes of transmission. For hepatitis E viruses, fecal oral way, that's the way of contamination by the consuming of contaminated food and water. The incubation period, that's the period which embraces the inoculation of the organism, which means the entrance of the virus up to the onset of the disease. In other words, the appearance of the first symptoms. You see, it's quite different in between these types of hepatitis. For example, for hepatitis E, this is it occurs from 2 to 6 weeks. Much longer for hepatitis B, and the same for hepatitis D, and hepatitis E, that's between 4 and 5 weeks. Frequency of the chronic disease is also a very important feature, because in case of hepatitis A, we'll never expect this hepatitis in the chronic form. In case of hepatitis B, approximately 5 to 10% of the hepatitis could be released into the chronic hepatitis B. Hepatitis C is much frequently, almost all the cases, more than 80% of the hepatitis C cases can be released into the chronic form. Diagnosis, basically, as the confirmation detection of the immunoglobulins and PCR reaction. That's the universal thing for the When we're talking about the chronic and acute hepatitis, we should describe the basic histological features of that. So, what is the big histological feature for acute hepatitis? See, they are here, and this apoptosis or ballooning degeneration of the hepatocytes. Also, we may find the areas of the intralobular cholestasis. Then mononuclear infiltrate around the triads in the ports in most of the cases. So in case of the chronic hepatitis, we see the updating of these events. Still, we may find the apoptosis, which aggregates. However, we see the development of nuclear infiltrate. We see the development of the fibrous tissue and replacement of bridging necrosis in fibrous tissue. We see the ductal reaction, the proliferation of small ductili in the liver. We see the development of the portal fibrosis. We see some interface hepatitis, which means that some isolated hepatocytes could be surrounded by the lymphocytes and fibrous tissue. In some types of viral hepatitis, like you may find fatty changes. A very characteristic feature of hepatitis B does the appear in hepatocytes. I will describe you a bit later. Viral hepatitis. On this image, you may see you may inspect grossly the liver specimen, and you see that this liver involved by mild acute hepatitis, which appear almost normal, mottled. See slightly mottly cut surface. At the other end of the spectrum, there is the massive hepatic necrosis. And the liver may shrink greatly as under acute liver failure, what we discussed before. And also you see the surface of this liver also shrunk, wrinkled. That's like the confirmation that there is some collapsing of the liver parenchyma. In case of acute viral hepatitis B, microscopically, we may find the ballooning degeneration of many hepatocytes. They are indicated by, okay, they're not indicated. I will indicate you by myself. That's the ballooning cells. You see the vacuoles within the cell cytoplasm. You may find the apoptosis, the single cell necrosis, as the formation of the concealment bodies. In case of viral hepatitis E, there are some specific features which are exactly for this type of viral hepatitis. I want to say about the neutrophil infiltration. Maybe you remember that the neutrophil infiltration is the characteristic of acute inflammation in response to bacterial infection. But in this case, we see the inflammation in response to viral infection. That's something that is characteristic for this type of hepatitis, not for others. In case of hepatitis B, as I told you before on this schematic on the diagram, the most important morphological feature of this type of hepatitis, that's the ground glass hepatocytes. You see that their cytoplasm is not granular, it's homogeneous. See, in contrast to the slightly vacuolated cytoplasm, or granular cytoplasm of the normal, non-infected hepatocytes. So these cells are infected, and they reveal the proliferation of the virus, which could be confirmed by the specific immunohistochemical staining against the HBs antigen. Also, the important characterization of any hepatitis, that's the activity. In case of active chronic viral hepatitis, we're talking about the chronic condition, but this chronic condition was exacerbated by certain factors, and this exacerbation is associated with the increased infiltration by the inflammatory infiltrate. So over here you see the portal triad, which is expanded but mainly mononuclear inflammatory cell infiltrates. The limiting plate of hepatocytes around the triad has been breached, and you see the appearance of these inflammatory cells. Over here, there's extension them to the adjacent hepatic parenchyma, and also you see the as a result the necrosis of the adjacent hepatocytes. What is the problem with the life? What about now? Do you hear me now? Please response. I just want to make sure if we continue which are watching. Okay. Problem with the life. What about now? Okay, well, I just want to continue. Perhaps the stream will reach you a bit later. So, as about the viral, we may find that there are. So, the next point of our lecture today, there's the alcoholic liver disease. There are some keynotes about this condition. You have to know that alcoholic liver disease is a chronic disorder that can give rise to steatosis, alcoholic hepatitis, progressive steatofibrosis, and marked derangements of vascular perfusion, leading eventually to cirrhosis. Also, in this case, we are talking about the consumption of more than 80 grams per day of alcohol, which is considered to be the threshold for the development of alcoholic. Take 10 to 15 year chronic alcoholics, and multiple pathologic effects of alcohol include changes in lipid metabolism, decreased export of lipoproteins, and cell injury caused by reactive oxygen species and cytokines. You see, there's the major stages of the alcoholic liver diseases, which are steatosis, alcoholic hepatitis, and final stage disease, that's the cirrhosis. And you see the interaction. So, hepatitis and steatosis, that's the uh, reversible forms of the alcoholic liver diseases. Then the cirrhosis, that's almost irreversible form of the end stage of the alcoholic liver disease. You see the gross appearance of the hepatic steatosis. Uh, that's the result biochemical background of that. That's the increased lipid biosynthesis from generation of more NADH by alcohol dehydrogenase and acetaldehyde dehydrogenase impaired assembly and secretion of lipoproteins and increased peripheral fat catabolism. Another histological feature of alcoholic hepatitis, that's now about chronic alcoholic hepatitis, that's the formation of the red globular Mallory Dank bodies, so-called alcoholic hyaline. That's the intracellular accumulation of the components of cytoskeleton, cytokeratins. Anyway, even when we're talking about alcoholic cirrhosis as the end stage of the disease, it doesn't mean that this process couldn't be reversed for a little bit. Because you see, then the person uh, uh, is active drinker on the left image. You see the continuous development of the cirrhosis and septa, fibrous septa, much thicker than in normal case. But later, if the person is following long-term abstinence on the right, see that the thick bands of collagens becoming thinner and most scars are gone. That's the result of a remodeling of the collagen. Also, you should know something about the inherited metabolic liver diseases. First of all, there's the Wilson disease, hemochromatosis, alpha-1 antitrypsin deficiency. Hereditary hemochromatosis is caused by a mutation in certain genes and characterized by increased accumulation of iron, which finally leads to the damage of hepatocytes. The same for the Wilson disease. It's another pathogenetic mechanism, but it leads to the same, the injury by heavy metals of the hepatocytes. Wilson disease also may demonstrate the as well as the hemochromatosis may demonstrate development of the liver cirrhosis. And this is the specific mechanism of the development of the hemochromatosis. And then development of morphological features of hemochromatosis. You see the appearance of the iron, which could be confirmed by the Prussian blue staining. And you see it looks like the cirrhosis. You see the nodule and you see the thick bands of the fibrous tissue. In case of Wilson disease, we also may find copper accumulation within the hepatocytes, which could be confirmed by the specific copper staining. And alpha antitrypsin deficiency, that's the autosomal recessive disorder of protein folding, marked by very low levels of circulating alpha-1 antitrypsin. It could be caused by variation of genes that are encoding serine protease inhibitor. Clinically, we see development of the cholestasis in newborn, hepatitis in adults, with sequelae in liver cirrhosis, and panacenar emphysema in lungs. See the accumulation of the alpha-1 antitrypsin, which is confirmed by the PAS stain. To liver, other branch of the liver diseases, that's the diseases which are associated with the autoimmune cholangiopathies. That we include the primary biliary cirrhosis. In this case, we see the major morphological feature as the florid duct lesion. You see the autoimmune response against the bile ducts could be released into the formation of some kind of florid duct lesion. Primary sclerosing cholangitis, it's another autoimmune disorder which mostly focused on the development of the scar tissue around the bile duct. It looks like onion skin concentric scar. And multiple types of liver tumors. Most important, most prominent of them, that's the hepatocellular adenomas. Uh, that's the HCC, the hepatocellular carcinoma, and cholangiocarcinoma. You will read about that if you want. So they are quite different, and they look different, and the aging is different too. They also have the specific markers. For example, for hepatocellular carcinoma, there's the release of the alpha fetoprotein, which